So let's move with some alacrity through the questioning. Who's got a question? Go ahead, Jonathan.
A quick question. Ollie, that was a terrific presentation, and fortunately I had sort of had done my homework so I could keep up mostly with you. But here's a question. You know, sometimes there's been debate in the past in the census as to how much imputation was sort of considered okay versus just using the numbers. And I know that in your work on counties, there's a fair amount of imputation just because there are counties in Nebraska with like 43 people. And it's really hard to kind of make a lot of inferences based just on sort of the actual data. My sense, though, is that your state level data over time, which seems highly appropriate, is that pretty much just kind of you have enough sample sizes in each state so that there's less imputation involved? Do you see what I mean, my sense is it's probably not very much, like it's the raw data.
So for us, when we do small area estimate, very good question, by the way. When we do small area estimate, even if there is, I cannot grade you if you don't take a test. But if you took one test, I can use that information. So for us at the county level, when it comes to mortality, we have few events that are happening. So we have to borrow strands from similar SES over time and geography. And then in order to do, so the model depends on the number itself and on the covariate. But what we do is we validate these estimates in county where they have a large sample size where we sample down and we validate our models. So when we have a number for a county, that's not difficult for us to impute. When we don't have data whatsoever, that becomes so hard. For the United States, this issue of imputation is not a big issue compared to something like in Africa. The imputation part is, for example, we try to link NHANES and BRFSS for undiagnosed, diagnosed blood pressure, controlled and controlled blood pressure. Diet is a big problem for us, even at the state level. So some of the issues are difficult. So we rely on sales data, we rely on other data. What we do is what she described. We combine all different sources of data in order to get something.
Thank you all again. I have a few short questions, I think, that go to everybody. But first to Ed, you talked about the objectives needing to be buttressed by feasible interventions. And I guess the question is that the objective needs to be able to be moved. So I guess one question is, what constitutes feasibility? I mean, if we were to redistribute income throughout the United States, you know, that's sort of feasible in theory, and you would probably move a lot of great health indicators. How do you parse feasibility?
You know, that's not something that I typically do. But you really raise a very important point, and it's one that has disturbed statisticians for a number of years. And for probably the third time that I can recall, there's a movement to try to get away from what I would call bell-shaped thinking, which is looking at intervention studies, papers that have been done, and looking at it in terms of, is there a statistically significant difference? There was a recent issue of the flagship publication of the American Statistical Association that included something like 45 different approaches that don't approach the assessment in that fashion. And I think we're going to be seeing, at least I hope we do, thinking that is more critical in terms of, and at the same time more flexible, that doesn't simply look at it in terms of whether there's something is statistically significant at the 0.5 level. Because if that's what's being used, you really don't know. I mean, the practical nature of this is you really don't know if it's going to apply to a different population than the one that the study was done on. And you hope that in the assessment of a particular intervention, okay, and that assessment being that, concluding that it will make a difference, okay, you hope that over time, as this intervention is applied, it is tracked. Now, this is something that Healthy People doesn't do itself, but I would hope that there is an effort to monitor the interventions to see if the interventions are working. We certainly do monitor the impact, but it's important not only to look at the bottom line, the objective, and whether or not that objective measure is changing. It's also important to look at what interventions are being done. And they're done at several levels. There's national interventions, state, and then there's what happens at the most challenging level, I think, which is the county or the local level. And it's important to be gathering information about that and looking at it. I don't think there is a one way. I would argue there is no one way to judge whether an intervention absolutely will buttress a particular objective. But in this process, that is an issue that was raised as being crucial. We don't want an objective for which there is no information, no solid information. And solid in this case means that there were one or more, I would hope, more studies. Now, it's not something that the Secretary's Advisory Committee looked at. This is something that was done elsewhere in this process. But there is no gold standard for this. I hope it moves toward gold.
Okay. So quick question. Census data, it is being used in Healthy People 2030 for some of the baseline? It's a question. I'm just trying to understand a little bit more about the data sources. Yes. Okay.
yes.
Okay. And then last one for Ali, for you, the health adjustment. When you're doing HALIs for global burden, how are you health adjusting? What are you using to do that?
For us, for disability weights, you mean? We did surveys, including in the United States, survey where we ask people like the ladder question. So consider two people. John can't see somebody across the street versus Bill who can't hear in a discussion. Which one you consider worse? And then we ask questions. If you have 5 years living with this condition, would you like to live if you have this condition, would you like to live 5 years without this condition or live like another 20 years with that condition? And we score those, and then we assign disability for every condition.
So it's really just building from the disability methodology and then changing the equation to make it health adjustment. There's not a specific, other way that you look at health adjustment.
No, this is based on disability and how people view their disability and how they rank their health. And usually before GBD, before this round we did it, used to be on experts sitting and deciding that. We did it now by surveys in household and here in the United States.
Thank you.
So let me, okay, Sherry, go ahead. Then I've got a question.
Just curious, so in the new methodology, do you use people that are living with certain disabilities as part of the survey? And did you look at the data by people who have the disability compared to others, and what did you find?
Yeah. No, very good, not a random. That's no, it's a sample that includes everybody, so people who have disability. Now some of disability, I'm a survey person and Ed is here, and Amy is here. So some people with disability cannot answer questions, so sometimes it's very difficult. But yes, everybody is included if they can respond. There are legal conditions who you can ask and you cannot ask. So, yeah.
Thanks again for a great panel. I wanted to maybe connect the dots between the last presentation and maybe this one just a little bit, and this might be a question for you, Amy. In the last presentation, somebody mentioned say, thinking about things like structural discrimination, and it made me think about HMDA, the Home Mortgage Disclosure Act data. And I'm wondering what your thoughts are for kind of opportunities of using, say, HMDA, which is, of course, mortgage discrimination, redlining, to connect back to some of the things in the previous presentation on social determinants.
Sure, that's a good example of one that if you go and look at the legislation that governs the collection and retention of those data, it was specific about the data elements that should not be retained. And this happens in the justice space as well. So in this knee-jerk reaction to protecting privacy, you don't have access to some data that would really be useful to delve into that. You do have the data collection, and HMDA's, it is useful because you have the geography and the race data, but it would be great to have a whole lot more information than that. To move beyond it, I've looked into some commercial data whenever you're looking at what can be bought from aggregators. And I think that there are a lot of really rich sources, but looking at the legislation and the regs and whether they have already limited what you could use the data for is really important. So kind of creating that policy database, both at the federal level and then also whether there are any state laws that would hamper your access.
So, nobody's ever accused me of being very sophisticated about data and analytics and methods, but so I'm going to try these couple questions. Feel free to tell me that I'm way off base or not thinking about it. But I've been thinking about the concepts of data versus information and then leading versus lagging indicators. So first, data and information. My understanding from Don Wright and from what we've read so far in the advisory committee's reports is that there's a very ambitious purpose for Healthy People 2030 in terms of bettering the health and well-being of the nation. At the same time, we've seen a reduction in the granular indicators, the number of them from, I think, over 1,000 down to 300 for probably good reasons. So I'm wondering if the data generated by those 300 will produce the information we need to really address the ambition of the program overall, as well as the vision of the advisory committee in that sense. The difference between data and information and the tensions and how we should think about that, particularly given the last panel's conversation with us. That's my first question.
So I'll give you how I think about it, okay? And this has certainly come up. I think about those 300 and think about what it is they're measuring and the importance, it's not a good word, I don't know what another one, but for example, are these mortality measures? Okay? So we could have a set of mortality measures, then we have it within the 300, and then we have behavioral measures, and then we have measures that have to do with disability and so forth. Okay? And so you can think of ranking these in terms of what you think are the most important. And I'm not going to say which are the most important. And then you can compare that with with a set of 1,000 indicators, which we are actually 1,200 or 1,300 that we have for Healthy People 2020. And look at that and say, are we missing something that's valuable here or would be impactful if we could make changes in those objectives? And I think that's the judgment that one has to make, and I can't make that judgment because I don't know what the 300 are, and we did have an opportunity to look at them and assess them, okay, which we did, but not exactly in the way I'm saying, in which we compared it exactly to the 1,000. If one of those measures was maternal mortality, that was in the 1,000, but it's not in the 300, and I don't know whether it's in the 300. So they may drum me out of the committee here, I don't know. But if that were the case, I'd say we're missing something that is really valuable information for a variety of reasons. Number one, the level of that is higher in this country, and in some areas, much higher than it, from what I understand professionally, that it needs to be, that it could be, or should be, okay? So this is something where it can be reduced. So if you've got something in these measures, the 700 that aren't included in the 300, and it is possible to reduce those and have a significant impact, then I'd say there's a problem. But that's how I view the information. It's the information on the impact that you would have if you could deal with them.
When I think of information, I'm thinking of the number of police calls. I'm thinking of the number of arrests. They need that information at a local level for tactical decision-making for community safety. And they may also need data in order to do some strategic planning or to do some evaluation. But the understanding the record system that is capturing the information on transactions, encounters, things of that nature, that's important, and there are quality issues there. Whenever you're considering that as data and you're starting to normalize it and draw insights from it, that is something that statistical agencies do a lot of, and then you need to know, if you're in that process, what you're attempting to measure. So if you're creating a measure, from my justice example, if one of your health indicators is number of touches to the justice system in the past year, or whether you have a parent that has ever been incarcerated, you need to have an understanding of the information generating as well as the data management and data curation in order to get your measure. So I see it as kind of a flow across the terms that you used.
Quickly, so your objective here is, at the end of the day, the 1,000, you're not criticizing, but you'll be 1 mile long and an inch deep. You really want to be very specific, especially in this day and age, because somebody can game it and game the one. So you need to pick indicators that you have a good measure for them and very informative. That's one. But for me to answer you and not make your job easy, I'm going to tell you something that contradicts what I just said. For some of the indicators, as Ed was mentioning, even if you don't have a good measure for them, I urge you to add them if they are important, because automatically you create a demand for people. So for example, controlled and uncontrolled blood pressure is very important, and we don't have a good measure for it right now because NHANES does it at the national level. We want it at the local level. But I will urge you to have it in order for people to go and get the data for it and do it. We have debated at GBD that certain conditions where we have a wide confidence interval, we provide a confidence interval for every estimate. That if you come, I showed you testicular cancer at the county level, I'm very confident about the number. In Togo, wide confidence interval. If you don't report it with the wide confidence interval, are you sending a message at the state and the local level that that's not important for you and your people? That's the risk. So yes, be small. You don't have to get a strong measure for a variable, but put it out there so we can improve our measurement. Think creatively about a tracer. If you can't measure it, can you get a tracer for it? Health access and quality of care for us, we can't measure it in the United States, but the tracer was the mortality data.
Just one more point. The 700 were not necessarily independent of the 300. So, for example, one of them might have been reducing blood pressure in a particular population. And one in the 300 might be simply reducing blood pressure. And what you, at least my thinking in reviewing these, was that maybe it's enough to say reducing blood pressure, because at the local level in particular, the local officials will be looking at disparities. Okay? And they will pick up the point that there's a population that really has a particular problem. So it's not as if the 700 is independent for the 300, of the 300.
So I I'm going to cut myself off and not ask my next question. And I'm also going to cut off Darcy and not ask her question, because I think we do need to move the agenda along. This has been, again, a second terrific panel, very thought-provoking. So thank you so much.